calcium metabolism video part 3 looking at hypocalcemia, which is a decrease in plasma calcium of less than 2.15 millimoles.
So we can differentiate the cause of hypocalcemia into VD problems or PTH problems. Yes or no?
Yes, a decrease in VD or a decrease in PTH.
Yeah?
Yes.
So low vitamin D will cause low calcium, low phosphate. Understood?
Yep.
By causing vitamin D normally causes calcium reabsorption, phosphate reabsorption.
In the gut.
Yeah, in the gut. So if you don't have vitamin D, you're not going to absorb any calcium or any phosphate. So you'll have both low.
Okay.
The way you can cause that is two ways. Either deficiency in vitamin D.
Yep.
So you don't have any vitamin D. Or you have the vitamin D, but you don't metabolize it into the active form.
And the active form is called
125 OH2D3.
Okay.
Yeah? So let's start by vitamin D deficiency. How do you get vitamin D deficiency? One, either you're not taking enough vitamin D in your diet,
Okay.
which is common in developing countries, or decreased absorption in vitamin D. Yeah?
Okay.
So in people like dark-skinned people, like myself, or hijabis, like myself.
How are you hijabi? Just because you don't have any hair?
Yeah, that's what I call myself. Okay. Oh, so this is the cause. If you don't have vitamin D deficiency, in children it's called rickets, in adult it's called osteomalacia. Just remember the Asians, hijabis, cover up, so the osteomalacia.
Okay.
So you'd have low phosphate, low calcium because of reabsorption from the gut. Yeah?
Okay.
Low calcium will result to secondary compensation of hyperparathyroidism because your parathyroid's working. So you'll sense that you've got low calcium. So you'll try and secrete more PTH, which will lower even further phosphate. So you'll become low calcium, low phosphate. So in the exam question, when you're given low calcium, low phosphate, it's a vitamin D problem.
Okay.
Yeah? So that is a deficiency or an absorption problem. Yeah? Secondly, disorder in vitamin D metabolism.
So does hyperparathyroidism?
Yeah. It will not compensate significantly for increased calcium. You'll still have it low because the compensation is so much that you don't have any vitamin D.
But
remember, in
wouldn't
us,
hyperparathyroidism secrete PTH?
but it can only compensate to a significant amount.
Okay.
Remember, in us, ourselves, we have significant amount of vitamin D and hyperparathyroidism just to keep calcium normal. So it will not compensate enough to increase calcium. Calcium will still be low.
Okay.
But because it's working even to decrease phosphate, it will even exacerbate phosphate.
Because PTH causes the reabsorption of calcium in the kidney and excretion of phosphate in the kidney.
Yes.
So, secondary hyperparathyroidism, you get PTH secreted, which further exacerbates the effects of decreased phosphate.
Yeah, understood.
Brilliant.
Yeah. The second cause is disorder vitamin D metabolism.
Okay.
Normally we get 25 hydroxylation that occurs in the kidney, the liver, sorry. And this goes to the kidney and goes 1 alpha hydroxylation.
1 alpha hydroxylation.
Then this becomes active vitamin D. This is the vitamin D then that can cause calcium reabsorption, phosphate reabsorption in the gut. This is the one. Yeah?
It's the bad boy, active vitamin D, 125 OH2D.
So the problem is, it's either the liver's problem or the kidney. Because if you're not going to hydroxylate it, you can't get there. Yeah? Yes or no?
True.
So if you've got liver failure, one, you're not going to be hydroxylating the vitamin D.
True.
If you haven't got the kidney, you're not going to hydroxylate that 25-OHD to the active form. Yes or no?
True.
So liver failure will cause it. Renal failure will cause it. Drugs will cause it. Because some drugs would stop the hydroxylation of the vitamin D.
So anti-convulsant
Epileptic.
therapy.
Yeah.
Epileptic medics.
Or because you will still find the vitamin D, but you've got resistance in vitamin D receptor. Yeah?
Okay.
Do you understand? Lastly, we'll go quickly to PTH.
Before we carry on to PTH, the renal failure is due to vitamin D dependent rickets.
Yeah.
Because you have
Receptor resistant of vitamin D.
Okay.
So vitamin D is still made, but when it goes to bind to its receptor in the gut and the kidney, there's resistance.
so that comes from
So
renal
it-
failure.
No, this is a separate thing.
Okay.
So this is the inherited form of where some people are born with their receptors of vitamin D are resistant.
That has nothing to do with the kidney.
Nothing to do with the kidney.
Okay.
There's still formation of this.
Okay.
But this, when it binds to its receptor,
Yeah.
the receptor is not listening and doing the action it's supposed to do.
Okay, brilliant. Let's move on to PTH.
So low PTH, yeah, will cause calcium. PTH normally causes calcium reabsorption, phosphate excretion. So when you've got low PTH, you'll have low calcium, high phosphate, because you're not excreting phosphate, so you're keeping it in, and you're not absorbing calcium, you're losing it. So low calcium phosphate, high phosphate. So the causes are hypoparathyroidism. PTH is produced by who? Parathyroid. If you haven't got PTH, it's primary hypo. It could either be you're born with it, congenital, or acquired.
Yep.
Acquired in surgery, removal of.
Parathyroid.
Let's say example, like you've got primary hypoparathyroid, a tumor. Remember the hypercalcemia? The second cause was primary hypoparathyroidism, was due to a tumor in the parathyroid, benign tumor. What do you need to do? You need to excise the tumor. So that is normally acquired. So patients who are normally undergo surgery will be told, look, you're going to lose your parathyroid. Yeah?
Brilliant.
Second, pseudo-hypoparathyroidism means, pseudo means false. False hypoparathyroid. The hypoparathyroid is producing PTH, but the reason why it's false, it's receptor problem again. Receptor problem.
Resistance to PTH receptor, just like you had.
In vitamin D,
Resistance
dependent resistant type 1.
Brilliant.
Yeah?
So there's two types, type 1 and type 2.
There's two types, type 1 and type 2.
Okay.
Due to signaling, different signaling pathway problems.
Okay.
Yeah? Thirdly, magnesium deficiency. Magnesium is important for secretion of PTH. If you don't have magnesium, you're not going to secrete PTH. Yeah? So patients with magnesium deficiency will have low PTH. Low PTH, they'll be low calcium, high phosphate. Understood?
Yeah.
So we've covered the low vitamin D and the low PTH causes.
Okay.
Now let's talk about the symptoms.
Before we go on to the clinical features, can we just go on to this side of the board? To differentiate with the diagnosis, how you diagnose the cause of hypocalcemia.
Hypocalcemia.
Yeah.
So the first thing is we need to look at the calcium level to diagnose it. If it's low calcium, it tells us hypocalcemia.
Yep.
Yeah? The second cause we need to look at is the phosphate. If the phosphate is low, it tells us it's a vitamin D problem. Yeah?
Yep.
But then we can go on and find out other causes, because other causes of vitamin D is to look at the liver. Is the liver working?
So you already know it's a vitamin D problem. Now you want to know the source of the vitamin D problem.
Yeah. Is it the liver
Okay, so liver
or,
function test
or the kidney function?
or
Kidney
GFR test,
Yeah.
high creatinine.
Yeah. So if we find the liver is normal, but the creatinine is high, this patient's got a problem with his kidney. Kidney failure causing low calcium levels.
Okay.
So kidney failure. So when the kidney failure is not working, there's not going to be alpha hydroxylation failure.
Okay.
However, if you have low phosphate and low calcium, look at the LFT. Sometimes this patient can have high LFTs, which can talk to you about it's a liver problem, such as alcoholism or liver disease. And the kidney function can be normal. So this is a problem with 25 hydroxylation because the kidney liver is not working.
Okay.
Let's go. See, was the vitamin D. What about when you've got low calcium, high phosphate, This tells us